start. So welcome to all of you. Hope you are having a good morning or afternoon, wherever you are. We are absolutely delighted to have you to talk about my favorite topic of outcomes measures. This is a third in a series of webinars. We are hoping to offer more of these. So if you have suggestions for the topics to cover or questions to address, we're all ears, would love to hear your suggestions. Also, if there is a different mode of providing information that would work for you, please let us know. You can put it in the chat, or you can send us an email at your leisure. So welcome to all of you. My name is Dagmar Emtman. I am the principal investigator of the Burn Model System National Data and Statistical Center. I am a health outcomes researcher. My training is in statistics and measurement, so that includes item response theory and other ways to develop and evaluate measures. This third webinar will be on outcome measures. It'll be a brief walkthrough. We have about 45 minutes, and then after 45 minutes, I will open the floor to questions. If you have questions in the meantime, please feel free to put those in the chat. We'll be monitoring chat and we'll respond as best as we can, either during the webinar or after, or during the Q&A session. So here are the first two webinars. They are posted on our website. They offer an introduction to the burn model systems and the database, as well as a case study in how to use or request the BMS data. So I will not be covering those topics today for the sake of time. So if you're interested in those topics and learning more about the BMS or the database, please log in and look at the webinars that are posted. So today, what I would like to do is give you a brief overview of how we select measures, what the criteria are, the process of it, how we think about the measures we select, and then walk you through some of the measures that we have in the BMS data collection. I won't have time to cover all the measures, so I'll cover as many as I can. There are more slides than I will likely cover, so we can either pick that up on an additional webinar if you think that would be interesting, or we could answer any questions you may have via other means. So very briefly, the burn model system is a national research study. It's funded by the National Institute on Disability, Independent Living and Rehabilitation Research. We have 4 clinical centers that collect data. We include those data in a database. We follow people with burn injury longitudinally, ask a lot of questions at different time periods. And all of the data ends up in the national database, which we manage and use to investigate different topics related to burn injuries. Most of our participants have moderate to severe burn injury because of our inclusion criteria. So our participants are not necessarily representative of the universe of people with burn injury out there. If you'd like more info about what is in the database, how to request data, all of that is on our website. or you can also email us and we'll be glad to help you and walk you through it. So with the very broad view, there are two different types of data in the BMS database. The first type are individual questions. So there is no scoring involved, the responses are the scores. And these individual questions involve patient demographics, prehistory, pre-injury history, causes and injury characteristics, treatment-related variables such as length of hospital stay, ventilator days, surgeries, treatments, hospital discharge-related variables, sponsor of care, that is insurance, where the person was discharged to, and also information about employment and school status. We will not be talking about these individual questions today. We will be talking primarily about the second type of measures that we have in the database, and those are standardized multi-item measures. These measures include several items. The scoring can be done using simple summation, or it could be more sophisticated, such as using item response theory, and I'll tell you a little more about that, but not in depth today. So we use standardized multi-item measures to measure symptoms or problems, such as pain, age, depression, post-traumatic stress disorder, sleep problems, fatigue, or health indicators such as physical function, community integration, satisfaction with life, and social health. What we collect are patient-reported outcome measures, and what those are they are direct reports from the patients or persons who are reporting without any interpretation by healthcare providers or researchers or anybody else. We value PROMs because they are the only way we can get the patient's point of view. And there are many types of situations where the patient or the person is the only person who can meaningfully report on how they're feeling or how they're functioning. The FDA recognizes the importance of PROMs and typically requires that those be included in clinical trials and research studies in order to provide the patient perspective. A little bit about why we use standardized questionnaires as opposed to individual questions. With individual questions, what we get are categorical responses. So let's say 1 to 10, or a little bit, somewhat, very much. Those cannot be scored in any other way. It's the response itself that is a score to that question. While in standardized questionnaires, we have several questions, which increases reliability of the score that we get. We also get continuous scores, which are better to use for statistical analyses and provide us with more statistical power to find relationships when relationships are there. With individual questions, there are limited ways to assess reliability. And by reliability, I mean the amount of information versus noise in the score. Each score has both the amount of information, what we're measuring, and some amount of error, some amount of noise. And we're trying to minimize that noise so that we get as strong a signal as possible. What that allows us to do is to use smaller sample sizes to find smaller treatment effects or smaller correlations between variables. and as such, it lowers the demands on the research study. With standardized questionnaires, we have excellent ways of assessing reliability. We get a lot of information, and I will show you some examples of that. With individual questions, it's difficult to assess what reliable change is. When you think of something like pain intensity, 0 to 10, is it meaningful when a patient moves from pain intensity of 3 to pain intensity 4? Or do they need to move at least 2 categories from 3 to 5 in order to feel that in real life? So there are limited ways to assessing that with individual questions. With multi-item questionnaires, we have much more sophisticated ways to assess sensitivity to change and also to make the scores actionable, so we can base treatment decisions based on those. With individual questions, you can only compare them across studies if the same identical question is asked. With standardized questionnaires, because the questions are standardized, they can facilitate comparisons across studies and also across different populations. With individual questions, we often have no norms or limited norms. With standardized questionnaires, we often have excellent population norms, which help us interpret the score and put it in a context of the general population, or all women or people of certain ages. So it helps us better understand what the scores are telling us. So how we select measures. And measure selection is a fairly involved and somewhat complicated process. In general, we follow the COSMIN evaluation criteria. These are criteria based on scientific recommendations. They are well described, and if you're interested in those, here is the URL. You can look at them. They provide a lot of different tools for evaluating measures, but really there's no two ways about it. The process is pretty long, requires a lot of research, because the information you need to evaluate a measure isn't always available in one place. So it requires a lot of reading, a lot of research, and putting it all together and weighing different types of criteria. When we choose measures to be included in the BMS data collection, we look at numerous indicators. These are just the most important of those. There are more that we use to make a decision. The most important ones that we never skip and never compromise on is evidence of validity and reliability. We want to see that published. We want to see both validity and reliability clearly and adequately described. We want to see clearly the psychometric properties of the score and the measure, and that includes unidimensionality, how the measure is scored, and what information is available for users in user manuals. We look for measures that are publicly available. That means free and available to anybody, not just free to us, but free to anybody, because that facilitates research and use. And therefore, we have better ways then of comparing our results with the results in different populations and different studies. We look for scales or item banks that have published item parameters, so that we can construct our own short forms if necessary, and we are looking for measures that allow for public scoring, so where scoring is not charged for. We carefully look at the length of the measure. We evaluate the respondent and administrative burden, and we give preference to measures that can be administered by computerized adaptive testing because it shortens the time of administration. And that means we give slight preference to measures that were developed using item response theory. I just want to say right off the bat that there are many, many excellent measures that were developed using classical chess theory that do not use item response theory for scoring, and that is perfectly fine. There are measures that have excellent psychometric properties that were not developed with IRT. An example would be something like PHQ-9. We look for clear construct definitions. We want to have a clear understanding of what is being measured, not just that, let's say, pain is being measured. We want to know if it's pain intensity, pain frequency, if it's temporal duration, if it's interference. So we want very clear conceptual description of what the score actually, what information about that construct the score provides. We look for scales that give us ways to interpret the scores, so that would include the norms or sometimes cutoffs or some other ways to evaluate what the scores mean. We give preference to scores that offer us continuity from peds to adults. There are very few of those measures, but a few have started to be available where you can follow people from childhood into adulthood, and you get a compatible score across the age. We look for measures that are compatible with what other model systems administer. That would be spinal cord injury model system or traumatic brain injury model system. We also look to national health surveys and try to use measures that are used by those surveys. That gives us excellent way of comparing our populations to the national samples. We prioritize generic measures for universal health constructs. So that means that when we are looking to measure a health domain that is applicable to all populations, let's say something like depression would be diagnosed and treated in all populations the same way. So we want a measure that is not disease specific, in our case, burn specific, because that would prevent us from comparing our population with other groups, and it would prevent us from learning from their research. We also look for measures that were developed with feedback from the target audiences. In our case, we look for measures that were developed with feedback from people with burn injuries or other injuries, or people who experience chronic conditions. We look for measures that have translations available. The BMS administers all our surveys in English and Spanish. So at the minimum, we'll look for a Spanish translation. But if there are more translations available, that is welcome, as that again facilitates research across countries. And last but not least, we look for measures that provide interpretable and actionable scores, something that is meaningful, that tells us something about what we learned about the person or a group. So we look for clear cutoffs for, let's say, mild, moderate, severe disease, or cutoffs for depressive disorders or PTSD, something that has good population norms. And we also look for estimates of important differences so that we know what difference in the score is likely to be a reliable difference that the patient can actually feel and observe, rather than a natural variation by chance. Here are some of the measures that we administer in the BMS. On the left, there is the health domain that we are attempting to measure. And on the right is the actual measures that we use. As you can see, some measures change over time. And that is because better measures become available. When we change measures, we do that after a lot of consideration. And we try to only do that when we have a way of maintaining continuity of measurement, and that often includes what we call crosswalks. So for instance, in terms of health-related quality of life, we crosswalk SF36, SF12, VR12 scores into Promise Global scores, because Promise Global is what we use now. So we have started collecting Promise measures about 9 years ago as they became available. They tick a lot of these selection criteria boxes that I just went over. They are person-centered. They were developed with a lot of feedback from participants. They are intended to be used with the general population, as well as with individuals with chronic conditions. The measures are free. There are many translations available. Not all translations are free, though. So sorry, changed my slide by itself. There are many translations available. Some of those you have to pay for. Spanish, which we use, we don't have to pay for. All the English versions are free, though. There is well-documented reliability and validity of Promise measures. There are good estimates of important change. For most of the Promise measures, if they are not available, there is still a good rule of thumb where we can use a half a standard deviation or 5 points as an indicator of minimally important difference. All Promise measures have clear definitions and a clear conceptual framework. They are all scored using item response theory, and the IRT scores are transformed to a T metric. That means the mean of 50 and the standard deviation of 10. And for most Promise measures, the score of 50 represents the US general population mean, which gives us an immediate interpretation of the score. There are also excellent population norms. So you can look at the score in general, or you can look at the scores by sex, education, and age. There is a lot of information available about Promise measures. You can look at healthmeasures.net or contact them if you want more information. So how this works? So for all Promise measures, and really all measures, each response has a score or number assigned to it by the developer. These scores are printed on the PDFs that you get from PROMIS. And we score by summing the individual item scores and then converting them to a T-score metric. You can use scoring tables to score short forms, or you can use the scoring service, which is available on the website if you use a unique set of items. And of course, if you administer by computerized adaptive testing, the algorithm provides a score for you. It provides the individual item scores as well as the overall score on a T-score metric. As is recommended by the PROMIS, we do not use some scores for any purpose. We only use the scores that are transformed to the T-score metric. So as you use those measures, always remember to do that conversion, because all the validation and reliability, it only applies to the T-scores, not to the sum scores. So the first measure I'd like to kind of talk about and show you is called PROMIS Global. Sometimes it's called PROMIS 10. It's a generic health-related quality of life measure, includes 10 items, and provides 2 scores. And you're gonna hear me talk about scores because in measurement, everything is about scores. Measurement is assigning numbers. So the scores are the numbers that we assign. And we have to make sure that those numbers mean something, and we need to describe well what they mean. So in this case, PROMIS Global provides 2 scores. One is global physical health, and the second is global mental health. Both of these are summary scores of health and mental status, and the higher score indicates better health. So with PROMIS measures, you always have to pay attention to which way the scoring goes, because sometimes the higher score means better health, and sometimes it means worse health. So really important to pay attention to. PROMIS Global is scored using item response theory. However, it's not an item bank. Unlike the rest of the PROMIS measures, PROMIS Global is a fixed length short form. And so what it means is that every person gets administered the same items, and those are the 10 items that are on that form. As I mentioned, we can crosswalk PROMIS Global to other commonly used quality of life measures such as EQ-5D, SF-12, and VR-12. And so what that allows you to do is use data from many different studies and populations and create large sample sizes. One thing to know about PROMIS Global, which is true of all global health-related measures, is that scores are relatively stable. So it takes a lot of change to move that score. This is true of all the global measures, because when you think about it, there are a number of things that are number of health domains that are measured that go into that score. So if you want to change the score, you need to change on the number of domains to actually see a difference on these global scores. So if you are used in studying change, I would suggest that you not use PROMIS Global, but that you use a more specific measure to the health domain you're interested in studying. So let's say you developed a depression treatment and you want to see if it's effective. As an outcome measure, I would recommend that you use a depression measure rather than PROMIS Global to see how much it changes. Because with PROMIS Global, maybe depression changes, but maybe not all the other domains that feed into that score. However, these are valuable scores because you can use these scores to look to control for health status in your statistical analysis. You can also conduct EPI studies that describe and compare populations. And you don't have to do it with 7 different scores, you just have 2 scores. And if you're primarily interested in physical health, you can use the physical health score. If you're primarily interested in mental health, you can use the mental health score, or you can use both. And I included on the PowerPoint references in case you're interested in learning more about the measures. There are a lot more publications about these measures. And so I just included the initial kind of development publications. This is probably hard to see, but this is what the global health form looks like. This is the investigator version. So when you look at this, it has the scores for the individual items printed here. When we administer this to the participants, we use the participant form, which does not include the item number and does not include the numbers, the codes for scoring. So you see here that we have instructions that are simple, because most often people just skip instructions. So these just say to respond to each question or statement by marking 1 box per row. And then the participant goes, reads the question, such as, in general, would you say your health is? And then they choose the best option that represents their health. We have 9 questions here that are IRT scored, and each question measures different health domain. So here's a physical function question. Here is a question about mental health. Here is satisfaction with social activities. There are different ways to look at somebody's health, like different aspects of somebody's health that we ask in these global measures. And the last question is actually scored on a 0 to 10 metric, and that is a question of pain intensity. Otherwise, the rest of the questions have 5 response options and are IRT scored. The last one is scored on a metric of 0 to 10. When you're scoring global health, be careful about how you score, because not all items contribute to the scores. So be sure to look at the user manuals and carefully follow the scoring algorithms, or use the scoring service that is free on the PROMIS website. Okay, the other set of measures that we use from the PROMIS suite of measures are the measures that are included on the PROMIS 29 profile. The profiles are combinations of individual PROMIS measures, and they were selected to cover key health-related quality of life domains. So these are individual measures. They are not scored across the different health domains. Each domain provides its own score. The PROMIS 29 is the shortest of the published profiles and includes 4 items for each health domain measured. 4 items is a very short form. So if you are looking to evaluate change in a score, let's say in a clinical trial, I would recommend that you use the longer forms, the 6 or 8 or even 12 item short forms, to make sure that you find smaller effect sizes. PROMIS 29 health domains cover physical health and include physical function, fatigue, pain interference, sleep disturbance, and also mental health domains, anxiety, depression, and social health domains, ability to participate in social roles. And then we have a pain intensity item as well. Scoring is done the same way that all of the PROMIS measures are scored. The higher score indicates more of what is being measured. So a higher score on fatigue indicates more health problems, while a higher score on physical function indicates better health. So always important to look at which way the score goes. For anxiety, depression, sleep disturbance, and fatigue, higher score means worse health. For participation in social roles and physical function, higher scores are better health. PROMIS 29 provides 7 individual continuous IRT-based scores, 1 for each health domain, and they are not averaged or in any way totaled, or they do not provide any overall scores. So don't use those, don't use the overall scores. Here is what the PROMIS 29 looks like. This is the participant version. So you can see there are no item numbers and there are no numbers under the choices. So we don't use the codes. We don't provide the codes to the participants. Some of these have different time frames. Some of these, so physical function has no time frame, so indicates right now, are you able to do these things? And the response options go from without any difficulty to unable to do, while anxiety has a time frame of past 7 days and a time frame of never to always. So does depression and fatigue and most of the measures, as we discussed. So these are scores that we collect. I just want to give you an example of what we look at as a data center when we select the measures. These are graphs that are produced by item response theory software that analyzes and scores measures. So what these mean is this is physical function here. This is reliability or information, as we call it in IRT function. So when we look for reliability and we want to compare groups, we look for at least 80% reliability. So that's here, 0.8. If we want to compare individual scores to each other for one person, then we look for reliability that is higher, at least 0.9. Down here is a histogram of where the people in our sample scored. So you can see we have a lot of people in our sample that have excellent physical function. In physical function, lower score is worse health, higher score is better health. So we have a lot of people who have physical function better than the mean physical function. And we don't do a very good job of differentiating these people. We can't tell you which one of those are Olympic athletes and which ones are just regular Joe Schmo who have good physical function. And we don't worry about that very much because they have good physical function and we don't really need to help them with anything. We don't need to provide referrals. We don't need to worry about their physical function. We worry more about people who are down here, whose physical function is below the mean. And this measure of 4 items that does a very nice, reliable job, provides a reliable, precise score that has very little noise in it. Of most of the continuum from scores as low as 25 to scores as high as the mean. And then at 0.8 reliability, 80%, which is good enough for group comparisons at the lower levels of physical function, like here from at less than 25. And in depression, so what we look at is what is the continuum, what span of the continuum is measured with sufficient reliability when we choose measures. And when 4 items are not sufficient, then we administer more items. In this case, we found that 4 items do an adequate job with physical function. With depression, we administered both 4 and 6 items short form and administered both. And again, depression, the mean is 50, so you see it here, but with depression, lower score is better and higher score is a problem, means more depressive symptoms. So we have a lot of people in our sample that have very low depressive symptoms, and we're happy for them and we don't worry about them, and we don't worry about the precision with which we measure them. We do worry about people who are at risk for major depressive disorders or who have higher depressive symptoms. So these 2 lines, or this higher line, is the 6 item short form, reliability of that form. And this lower line is reliability of the 4 item short form. So this allows us to compare, would it be worth administering 6 items? Would it give us more reliability? And as you can see, the difference is pretty small. So we actually opted to administer a 4 item form. So this is the kind of information we look at. It's complicated, but it gives us a lot of information, a lot of flexibility in measure selection, also in whether or not we should construct focused or targeted short forms for our population, or whether we should use the published generic short forms. And the last of the PROMIS measures is PROMIS itch. We just added that in 2022. We replaced the measure that's called for the itch, and we replaced it because PROMIS itch is scored using IRT, provides 2 continuous scores, and has excellent construct validity and involved a lot of participants in defining 2 separate constructs of itch. And one reflects mood and sleep, and the other one reflects itch interference. So we now have 2 scores for itch, and we can choose which one we want to use in our analyses. Here is what the PROMIS itch looks like. So here are the 2 different subdomains at itch that are being measured. Okay, I would like to stop here. So from now on, we would go to measures that are classical test theory measures. And we have quite a few of those, so I'd be happy to provide more information about those. But I would like to stop and maybe see if there are any questions or if there are any comments on what we've covered so far. So please feel free to unmute yourself and chime in or indicate that you would like to speak and we unmute you, whatever you would like to do. Any questions, comments? Anything else you want to know about the promise measures? Okay, I don't hear any, so if nobody has anything, I will just continue covering the measures, if that's okay with you. So satisfaction with life is one of those workhorses of measurement. The measure was developed in 1985 and has been heavily used since, has some very nice properties, which allows us to compare people across many different conditions, diseases, or people who are healthy. So it is used in many different contexts. There is lots of publications and information about this measure. Because the measure was developed prior to broad use of IRT, the measure also has some issues. And when we conducted analyses of the measures in our measure review, we found that IRT would suggest that 5 response options would be more reliable than 7 response options. That means that from our analyses, it seems that people are unable to discriminate reliably 7 different levels of satisfaction with life, and that 5 would be sufficient. What we also found was that 5th item did not function well, and in fact lowered the reliability of the scale score. And so we actually dropped the 5th item, and I'll show you what that item is. Because this is the only outcome measure that all Neidler-funded model systems have been collecting since their inception, we continue collecting it, and we find it useful in comparing our populations. The way you score satisfaction with life is that you get 1 score, which is a score that tells you about how satisfied the person is with their life. And you sum the responses across all 5 items. In our cases, we score responses across 4 items because we dropped the 4 items. So we developed slightly different scoring. For the original scale, the responses, the scores range from 7 to 35, and the higher score indicates better, more satisfaction with life. There were no published general population norms, but there are a lot of publications with fairly large samples. And so when we want to compare burn survivors with other populations, we find a study that administers satisfaction with life, and we compare our mean with their means as a kind of a norm. So you can use it that way. There have been cutoffs developed to aid interpretation of the score. So you have the cutoffs here. People use these cutoffs or slightly different cutoffs. You can do a search and it will provide you with information about the cutoffs. And the satisfaction with life score scale is freely available. You can just download it and use it in your studies or in your clinical practice. Here's what the original original scale looks like. This includes the fifth item. The item says, if I could live my life over again, I would change almost nothing. And some of our participants with traumatic injuries considered that item almost offensive and sometimes refuse to answer the item. It also, the item seems to be independent of these other four items, and therefore we dropped it from our administration. I see there are any chats. Do we need to respond to anything? Okay, I guess we got the answers. Okay, that's satisfaction with life. Another classical chess theory-based scale we use in the BMS data collection is Community Integration Questionnaire, CIQ. We only use the social integration subscale because the full questionnaire is too long. We just cannot do that with all the other measures that we administer. The subscale provides one score. It provides a score that measures social integration. This is a questionnaire that has been traditionally administered in many traumatic injury populations, including burn survivors. We collected the whole scale until 2006, and then since then we've been only collecting the subscale. We have that subscale includes 6 items, and they ask about managing finances, activities outside the home, and social participation in activities. The scoring is simple. You sum responses across all 6 items. The scores for the subscales we use range from 0, which is very limited social integration, to 12, which is excellent social integration. There have been no general population norm published, but as with satisfaction with life, there are some very nice large-scale studies that have administered that questionnaire in different populations. And so using the mean of those scores as a comparisons is very useful and can be easily done. The CIQ is free. You can just download it and use it in your research studies. Here is what the measure looks like. It's 6 items, fairly easy to respond. Most items have different response options than the others. And this is going to be the last measure I will cover, and that measures post-traumatic stress disorder. We used to use PTSD checklist civilian version that was developed by the National Center for PTSD in the Veterans Administration. In 2022, we switched to PCL5, which is essentially an updated version of the PTSD checklist, and it's recommended by DSM-5 to be used. The change in from the PTSD checklist to PCL5 is substantial, and therefore the scores are not directly comparable. So we need to do a little bit of crosswalking if we want to combine data from PTSD checklist to PCL5 scores. And so that's what we do in our data collection. We try to avoid changing measures as well as we can, but the world kind of evolves, and we want to also administer measures that are current and have best evidence. So PCL can be scored in different ways. You can look at the total symptom severity score. You can look at symptom clusters, or you can make a diagnosis, depending diagnosis of PTSD or not. The PTSD can only be diagnosed by a clinician. So this is a preliminary indicator. So if somebody is at risk for PTSD, they probably need to be seen by a clinician and evaluated. Again, PCL-5 is freely available. It's fairly long, so here's what it looks like, and I know it's probably hard to read, but just to give you a sense for what it would look like if you wanted to administer this. All right, I'm going to stop here. We have more measures. There's more information on the PowerPoint. We have about 3 minutes. I want to give you an option to ask questions if you have any questions. If you want to provide suggestions to us, like what else we should cover, what we should go into more